Hi, this is Brian Kim. I want to share with you this case of a patient who had an opacified silicone 3-piece lens in the bag. And this patient also happens to have an open capsule. And so you're going to see the technique of very carefully extricating this lens from the capsular bag and then placement of a 3-piece acrylic IOL in the ciliary sulcus with optic capture. And throughout the procedure, you're going to see how I navigate around the challenges that occur when you have an open posterior capsule in the context of this opacified silicone lens. So you can see this is a patient. You can see the opacification of the lens. We can also see the YAG capsulotomy that was performed and some of the dings within the lens itself, because the surgeon thought that the opacification was in the posterior capsule, but instead it was actually within the lens itself. So I make my incisions first on the right side and then the left side, making sure I'm parallel to iris plane. I'm injecting some intracameral epinephrine. I'm injecting some dispersive viscoelastic. And this is a 3mm blade. I make a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, using the cannula to hold the eye, and then I'm entering. Using the prototype cannula to dissect the capsule off the lens optic, I'm able to get underneath the edge of the rhexis, and it's mounted on some dispersive viscoelastic. Push some dispersive viscoelastic to separate the anterior and posterior capsules, going around circumferentially here. You can see rather easy separation of the capsule from this silicone lens. And I don't recall how long ago the original surgery was, but I believe it's been quite some time that this patient had surgery, probably over 10 years ago. So I'm just going around, gently separating the anterior capsule from the optic. You can see this prototype cannula is working quite nicely, getting underneath the rhexis edge and pushing that dispersive viscoelastic, separating the anterior posterior capsules and trying to create some separation of the capsule fornix as well. The nice thing is the original surgeon made a great capsulotomy and with 360 degrees of overlap. This is the Lester. I'm just going to try to tease out that haptic on the left side, but it didn't really want to come out, so then I'm going to draw my attention to the right side. You can see that right side haptic is able to pop right out of the capsular bag quite easily here. Going to grab the lens with microforceps and then gently teasing the right side haptic out of the bag using the Lester hook. Very gently, just teasing it central, and then pops right up. And then doing the same thing on the other side, and I'm able to dial the left side haptic out of the bag as well. And now both haptics are in the anterior chamber. I have the microforceps, the serrated IOL holder in my left hand. Switching the Lester for micro scissors, go ahead and cut the lens. This is a silicone lens, so it's rather slippery, but with the serrated IOL holder, it grips it quite nicely here. When you cut the lens, you want to make sure 100% that you do not cut the anterior capsule. Because if you want to do optic capture, if you cut the anterior capsule, you're in trouble. You won't be able to do that technique. So very carefully cutting the lens in such a way that I don't cut into the anterior capsule. Disengaging the forceps from that left side piece, switching hands because I know I have to grab that lens optic with the serrated forceps, because the smooth forceps will not hold. It will just slip off, and I know that from experience. So I'm hands shaking all the way to the tip of the haptic, externalizing the haptic, protecting the cornea, pushing it down with the left side forceps, grabbing the cut edge of the optic, repositioning, grabbing it again, and then very carefully taking that piece out. Again, with the two-handed maneuver, grasping that haptic, repositioning the lens, grabbing the cut edge of the optic with the IOL holder, right there, and then shielding the cornea as I pull that lens piece out with the other forceps. Pushing some cohesive viscoelastic to expand the ciliary sulcus. And this is the Sensor AR40 lens. This is the cartridge. Placing some cohesive viscoelastic into the barrel and onto the wings, the platform. Placing the lens, seating it down into the platform, bringing the wings together, making sure the optic bends backwards, and the leading haptic comes straight through the barrel, and the trailing haptic comes outside the back. Placing it through the injector here, and making sure the trailing haptic is outside of the barrel. And I've used this lens many, many times for my Yamane techniques, so I have a lot of experience using this lens and loading this lens. And again, I use a 3mm blade to make my incision, so this injector cartridge should go in quite nicely. Very carefully wiggling it in, turning the bevel to the left, pushing some more viscoelastic simultaneously to fill up the ciliary sulcus, delivering the leading haptic into the ciliary sulcus, turning and rotating my hand so that the optic comes out nice and flat. And then using the Maltzman here to dial the trailing haptic into the ciliary sulcus. And because this patient had 360 degrees of anterior capsule overlap of the optic, I'm able to pop each side of the optic into the capsulotomy opening and a buttonhole configuration. I go in with a low flow setting and removing the viscoelastic from the anterior chamber, but as I do this, you can see there's vitreous coming to the port. So I stop, pushing off the vitreous off the tip with the cannula and trying to reflux as well. Once I free the port from the vitreous, I take it out and I switch to a bimanual anterior vitrectomy. And remember, the vitreous that's coming forward is going to be isolated because of the optic capture buttonhole configuration. It should limit any more vitreous coming forward. In this context, I don't think it's necessary to perform pars plana vitrectomy with trocar because, again, the vitreous is isolated by the buttonhole optic capture of the lens within the anterior capsulotomy. So I'm just pushing down with the irrigation cannula and just trying to get some of that lens material up and out. You know, why leave that stuff in there if I can get it out? I switch to IA cut mode, which more efficiently allows me to grab some of that remaining lens material that's within the bag. Again, I don't want to invite a whole lot of vitreous as I do these maneuvers, so just removing whatever is exposed to me here. In IA cut mode, you can see there's not much vitreous left over here. I come out with the vitrector and the irrigation sleeve, hydrate my incisions. And again, no evidence for vitreous thus far here anymore. I'm pulsing some BSS into the anterior chamber with the cannula to just pulse out some of that dispersive viscoelastic from the anterior chamber. And this is a tendonodon suture just to close the main incision. And in the context of vitreous loss, I always like to place a suture because you never know. Post-op, you can see vitreous to the wound, and that's just poor form in my opinion. So again, this is an opacified silicone lens in the capsular bag with an open posterior capsule. The surgeon obviously thought the opacification was in posterior capsule, but once he started lasering it and dinging the lens a few times, also noticed that the lens itself was cloudy. It's very easy to ding a silicone lens. I've done it myself as well. And especially when you think that the opacification is in the capsule, as you're trying to do the capsulotomy and you're trying to lyse those adhesions, it's easy to ding the lens. And then, of course, you realize that the opacification was in the optic. So very carefully using that prototype Kim IOL exchange cannula to dissect the lens off the capsule, I was able to free up the lens from the bag. And then once the lens was in the anterior chamber, I go ahead and cut the lens, again using the serrated forceps because the silicone lenses are rather slippery, pulling each piece out, and then placing the Sensor AR40 lens in the ciliary sulcus and optic capture configuration. There was some vitreous that came forward, but I did a bimanual anterior vitrectomy, which worked out fine. You can see right here, nice, beautiful buttonhole. That cat-eye almond-shaped configuration of the capsulotomy confirms that you have the buttonhole configuration for optic capture of the sulcus lens. And this patient ended up doing quite well. So I hope this was helpful to you, and I thank you for your attention.